Evening, everyone. Thank you to TIPS for again for bringing us all together, and special welcome to any newcomers to our session this evening, and hello again to old friends. You've all seen the slides regarding the etiquette. And I think we're all very familiar now with Zoom etiquette. Just a reminder to, if you can, put your hand up using the reaction button or waving if you'd like to contribute to the discussion. And a special plea to everyone to put your videos on if you wouldn't mind. It really does help to increase the participation, and thank you to those who already are happy to have the video on. I know some people don't have the bandwidth to do it, but if you can, that would be great. So this is our last session for 2022. Those of us in Australia are looking forward to some summer holiday break. I think our colleagues in India are just looking forward to continuing to work on. But we will probably take a break after this session, at least in January, regroup a little bit and start to plan ahead for 2023. I'll say more about that at the end of tonight's session. A reminder that we are being recorded, and I thought it might be worthwhile just reviewing some of the topics we have covered in the second half of the year. So we've looked at delirium. We had Gauri Gaudabole talk about that. We had a talk from Frank Brennan on renal failure, serious health-related suffering and renal failure. We had a talk about the importance of pain screening, and Dr. Melanie Lovell spoke to us on that. And then we had a discussion last month about the feeding dilemmas in late-stage disease. And Dr. Shirina Mirabu talked about that with us, or presented on that. And then alongside all of that, we've had some great case discussions from presenters, colleagues in India and in Australia. So I think it's been quite a diverse program, and I really appreciate the generosity of all the presenters, both the faculty presenters and the case presenters, because I know a lot of work does go into preparing these sessions. And so tonight we have very happy to have Professor Philip Good, who is a colleague here in Australia. Philip works as the Director of Palliative Care at St. Vincent's Hospital in Brisbane in Queensland, and is also a professor of the School of Medicine at the University of Queensland, and I think is associated also with the University of Technology in Sydney. And one of Philip's other claims to fame is that he's the editor of the Palliative Medicine Research Reviews. And I think it might be of interest, Philip, if you don't mind being put on the spot, just at the beginning, perhaps, of your presentation, just to tell people about that review, and because it may well be of interest to colleagues in India as well. I don't know if there is a similar sort of product, if you like, that's available to colleagues in India, or whether it already has an international following. So sorry to just put you on the spot there, but I'm sure, I know I always find it very useful as a clinician getting those reviews. And I hope the topic you're talking about today will find its way into your review somehow. So your work that you've done for this will also help you there. And I'll introduce the other two speakers just before they speak, but maybe over to you, Philip, to give us the talk of tonight's topic, which is on thromboprophylaxis for inpatients with advanced cancer in palliative care, and what do we need to know.
Thanks, Odette. Thanks very much. Yep, I think the Palliative Medicine Research Reviews, it's one in the stable of products that these I don't actually know who produces it, but there's actually a research reviews for every area of medicine. I think it's I don't know if it's available outside Australia, whether you can subscribe or not. feel free to send it around, Odette. I think the New Zealand people might have had trouble finding it, but it's just basically, actually, it's got the busiest year this year. You used to do it. This group does it, and they ask you to review about 10 articles. They're very brief, about 100-word summary of about 10 articles. Initially, the last few years, it was like once or twice a year, and this year's been about 8 times a year. Yeah, I always welcome feedback, and if anyone comes across interesting articles they want me to look at, it's just a brief summary, and I find it useful for myself just to see what literature is around at the time and what's available. And you know, it's a bit biased to Australia, to be honest, but I do review lots of things from around the world, and it's just a very brief thing if people are interested. So feel free to send it around, Odette, and people can see if they can subscribe. I don't know if you can subscribe or not outside as such. So I just want to check, can people see my screen there? Hopefully.
Yes.
Yes, great. So this was an interesting topic. I have an interest in this, but this is not something that's come up a great topic myself as such. So thanks for telling us that and asking me to talk about that. And I just wanted to, you know, and if people have questions, I'm very happy for people to ask questions as we go along. So I've had interest in this for a little while in the concept. And I guess the things I'll try and cover tonight are, you know, what is thromboprophylaxis? Why do we do it? What is the risk of DVT in the patients we see? The topic was very specific about advanced cancer and palliative care patients, and I'll sort of concentrate on them, but in palliative care, there's lots of variety of patients we see. So evidence review, what is current practice? What is the variation in practice, which is really staggering to me, the variation, depending on where you are. But then again, I can talk about what happens in my own area that I work, and what should we do in palliative care, which I think is a really big challenge as such. So I think this is a really interesting thing. I don't know if people are aware of this, but thromboprophylaxis reduces the risk of death in surgical patients in acute hospitals, but there's actually no evidence that it decreases mortality in hospitalized medical patients. And so it's always fascinated me. And again, I'm sorry that I'm pretty ignorant of what's happening in India, but in Australia, it's one of these really important quality indicators that people talk about a lot, in the sense that when people come for accreditation, they look at, you know, what's your quality around thromboprophylaxis. And it's fascinating to me because there is actually no evidence that it improves mortality in hospitalized medical patients. It's really this thing that happens in surgical patients. So certainly in surgical patients, it's really important. You could argue or not whether it's important in hospitalized medical patients. And then I guess in general, palliative care patients are a subset of hospitalized medical patients in general. So I think that's one of the really important things to start with, which when I talk to junior medical staff about this, they just don't even know that. It's just been sort of browbeaten to their head that everyone has to have thromboprophylaxis, and they don't realize that it doesn't actually improve mortality. It does probably improve morbidity in the sense that it decreases the risk of DVT, decreased outcomes in DVT. But, you know, just remember that. So just, I mean, that's really important. If you think palliative care is about treating people's symptoms and not making them live longer or shorter, that's one thing to start off with in terms of how you'd look at thromboprophylaxis. So I work across 2 inpatient palliative care settings, one in an acute hospital, where everyone who comes in, if they're a palliative care patient or a joint oncology palliative care patient, everyone seems to get Clexane or enoxaparin 40 milligram daily subcutaneously. And that happens to everyone. And then when they come across to, when they sometimes come to, so in the other place I work is a standalone subacute care hospital, which has got a 40-bed palliative care unit at St. Vincent's. And basically no one gets DVT prophylaxis when they come to us. So it is offered. Well, what happens is they're usually on it if they come from another hospital, not from the community. Often people say, do you want to continue this or not continue this? And like 90% to 95% of people say, I don't want to continue it. This is in the prophylactic setting. They don't want the injections. They don't want that. So it really fascinates me, and interesting. One of the fascinating things I found from look at these studies was that someone said in one of the studies that patients are very open to having it, which hasn't been my experience. But having said that, I always think about these, that the things that happen. So just recently, for example, we had I had a patient just last week who had advanced respiratory disease and a lung cancer, although his main issue was advanced respiratory disease. And he came into our inpatient palliative care unit, mainly for problems around constipation. And he had these things sort of getting fixed up, and his lung cancer was pretty minimal. But and another topic in palliative care is what's called sort of unexpected death. So he was sick, he was on oxygen therapy, but he was aiming to get home. And it was really fascinating to see that basically the notes from the nurses were, went to the toilet in the middle of the night, came back to bed, went back to bed okay, 4:30, found deceased. And so I wonder about whether this man had a cardiac event, wonder if he had a pulmonary embolism. And then you think, well, should I have given him DVT prophylaxis? Because this was a person who was in a general medical ward, would have got DVT prophylaxis. Similarly, another patient who's another inpatient that I'm looking after at the moment, who has got mesothelioma, a form of lung cancer, which happens in Australia, happens around the world. Anyway, she was in our inpatient unit about 3 weeks ago, or probably 2 or 3 weeks ago, and she came in she had fluid on her lung and she had fluid drained. Again, not off a DVT prophylaxis. She went home. She came in a week ago, so probably been home for about maybe a week. And then she came in because she'd had increasing swelling of her right leg. And it was very hard for her to get investigations because she was fairly debilitated. And it turned out that she had a DVT, and she got treated initially with Clexane and then oral tablets. And I wondered about whether, she would have benefited from DVT prophylaxis as well. Having said that, that's 2 cases out of many who obviously everyone else has not got DVT prophylaxis. So just, and we can talk about this now at the end, just interested in, so in Australia, at least anyway, there's, in my experience in hospital settings, in the medical setting, everyone just gets enoxaparin 40 milligrams once a day, unless you have a creatinine clearance less than 30 millimeters per minute, when you actually get 20 milligrams. And then occasionally people get unfractionated heparin, 5,000 units subcutaneously, 12 BD, and that's generally, I think, if you've got impaired renal function. I've rarely seen anyone get dalteparin as such. And then there's this thing which you see, which is mechanical prophylaxis. So that's graduated compression stockings. And I'm not sure if in the patients I ever see actually get this 16 to 20 millimeters of mercury. No one ever gets measured. And most people don't seem to like their stockings very much. There's intermittent pneumatic compression devices, pneumatic foot compression or pump. And actually, I don't see anyone getting that much. I mean, sometimes patients have these stockings on. So I guess one of the reasons why it's important to think about this is that there's these different scoring systems of risk of DVT. I must say that in acute hospital that I work in, everyone just gets DVT prophylaxis. But as you can see, there's a scoring system of what's your risk of DVT, or venous thromboembolism. And if you score 4 to 20, and if you have cancer, basically you get 3 points, which means that you only have to get 1 more point to get the higher risk, in which case they're suggesting they're at very high risk and should make sure they have it. And almost every patient who's got cancer, obviously, I would be involved in an acute hospital setting, has at least one of these other risk factors. So, impaired, reduced mobility for 3 days, duration, age greater than 70 is very common. Heart or respiratory failure is very common. So everyone's at high risk in reality, and cancer makes you at high risk. But again, if you look at this literature, so there's this guy called Simon Noble who has written a lot about deep vein thrombosis. And I think it's fair to say the history in palliative care has waxed and waned, in the sense that many years ago, no one would even consider giving people DVT prophylaxis. And then there was this sort of, I think Simon wrote, as far as you can see these articles about, we should be really considering this because people die from DVTs, PE, pulmonary embolism, and they get all these symptoms from it, which I'm not sure personally I've seen a lot of. And going back to the first patient, whilst he sort of died in his sleep and it was an unexpected death, his wife was saying the next day, well, that was really sad, but actually it was quite nice he died in his sleep. So that's the viewpoint that people have of deep vein thrombosis or pulmonary embolism. But Simon Noble's writings and viewpoint was that people were getting a whole lot of symptoms. So this was a really interesting study, and this was done by this lady called Claire White with Simon Noble about what happens to people who come into palliative care units. How many people have venous thromboembolism when they come in, and what happens afterwards. So a little bit hard to see here, but you start off with a whole lot of, and this is one of the issues, I guess, for all palliative care trials to a large extent. You start with a whole lot of people who are screened, and they become eligible quickly because in this, they looked at, I think we looked at these about 5 different units in the UK, and you had to have an estimated time of greater than 5 days to live, which, for a lot of places when the average length of stay is sort of 10 to 14 days, that, makes a lot of people not eligible. So there's a lot of people not eligible. So 60% start with not eligible. So that obviously gives you a biased population. And then it goes down about, then the eligible people, those eligible people, a large proportion decline participation. But, fascinatingly, they kept on going, and they screened all these people at baseline. So when they turned up and they discovered these people who had DVTs, who weren't known to have DVTs before, and some obviously didn't have DVTs. And then they looked at what happened during their stay and what happens in the end. And I found that fascinating to follow this, and we'll just go through this. So there was a longitudinal observational study, 5 units. So they learnt themselves to do these bedside ultrasound scans, and the ultrasound scans were ultimately reviewed by radiologists as well. So they wanted to know how many people, had a DVT when they turned up. And, interestingly, you look at this, 34%. So 1/3 of patients had a femoral deep vein thrombosis. So this is just femoral or lower limb deep vein thrombosis, not including things like pulmonary embolism. And so they looked at a whole lot of different areas of what could be associated with it. So, and the only things that were really associated with having a deep vein thrombosis on admission were previous venous thromboembolism, being bedbound in the past 12 weeks for any reason, which is probably a lot of people, and lower limb edema. So that was more like it was a sign of what was happening. And these independent predicted it. What was interesting was, and I can't remember exactly where all these people came from to come to these palliative care units, but even if you had DVT prophylaxis before you came in, it wasn't, it didn't make a difference in terms of overall whether you had a DVT on admission or not. So some people have been having DVT prophylaxis, still had a DVT on admission, despite that. And as you can see, in terms of, as I talked about, this anti-thromboembolism stockings or mechanical, just like in what I see, very few people in this setting have it as such. But you can see here that about 25 to 35% of people were on anticoagulation when they turned up to the palliative care unit. And I guess it's a very biased sample depending on where you come from. Obviously from home, not many people are getting it, but from other hospitals, they are getting it. And just to show you that survival, whether you had a deep vein thrombosis on admission or didn't have a deep vein thrombosis on admission, it didn't make a difference to survival. And some people got treated for it and some people didn't get treated for it because they were blind. They blinded the clinician in the sense, I think, that if the clinician would have normally ordered a scan for the patient, then they gave them the result of the scan. But if they would have normally ordered a scan, they didn't have to necessarily give them the result to see what changed over practice, which would have been an interesting ethical dilemma. So they came to the conclusion that these findings are consistent with venous thromboembolism being a manifestation of advanced disease rather than a cause of premature death. And they thought thromboprophylaxis for patients in palliative care units with poor performance status seems to be a little benefit, which is really interesting to me because Simon Noble up at that stage had been really thinking that we're really talking a lot of his literature about, we should really do this. So this is looking at what is current practice, and that's the article that was sent around. And I must admit, I didn't read every article in it, but I was really fascinated that someone had done systematic review and looking at this, and they really wanted to see what is the use of thromboprophylaxis, as well as what is the incidence of thromboembolism and bleeding in patients with advanced cancer. So very much this question that people are asking for this talk, and they did a systematic review. It was searched up into 2018, and you can go through the paper at your own leisure. But they found 11 full text papers, 9 quantitative, 2 qualitative. And I was really fascinated with this. The thromboprophylaxis use range from 4% to 53% for palliative care patients, which seems very high to me. And when I look at the inpatient palliative care unit I work at with 40 beds and, maybe an average of 25 to 30 patients, we would have 0 on thromboprophylaxis. We might have one person occasionally who wants it after being in hospital. And then interestingly, they found these venous thromboembolism rates between 0.5 to 20%. And that's interesting compared to that study that I just described, where it was actually, it was actually 30% or 35%. So quite high in reality. And the bleeding incidence was between very low to 10%. So that's one of the things I think we all worry about, this idea of you're giving people, so again, when we get to the end, but this idea of, if palliative care is about symptom control, you're giving people a intervention for something they don't have a symptom for that has a risk of side effects. So it would be an unusual tool we would normally use. And this other thing, risk assessment tools were used infrequently. So, we had talked about that risk assessment tool at the beginning, and interestingly, I personally had never used a risk assessment tool for DVT or PE, except for potentially in non-cancer patients in an ED setting. So I'd never used one. And physicians had obviously a variation in practice. And they say here, patients were largely accepting of thromboprophylaxis if it was offered. Now, that isn't personally what I see. But in hospital setting, they are accepting, but I wonder if they're actually ever given a choice. It's just basically, you have to have this and here's his needle. So another interesting and interesting in that research review that I do, I am quite interested in the variation of practice. And I think I have reviewed a couple of studies similar to this, where they basically ask palliative care or palliative medicine physicians. So for example, I know there's a study looking at delirium. How do people treat delirium? They look at palliative medicine physicians, geriatricians, even psychiatrists or psychogeriatricians. They give them case studies and say, how would you treat this patient? There's really some interesting ones around depression and psychiatrists and palliative care physicians, and how would you treat this depression? And it's really fascinating, the variation, a little bit from within palliative care, but very different across specialties, which is really fascinating to me. So this was looking at medical oncologists and palliative care physicians' opinion towards thromboprophylaxis for inpatients and in advanced cancer. So this was done in Canada, and they, it's hard. They did this basically. They had this. I'm trying to remember if they had 28 vignettes, I think, and I think the way they did it was that they had that they were split into 7 different areas, with each area of the vignette which varied, but with each in 7 area vignette that have 4 variations of that vignette. And so they would, depending on, they would just randomly give you the vignette as such. So something like they had 28 vignettes, basically around 7, what was called 7, so like 1A, B, C, D, and then 2A, B, C, D. And people got them depending on just randomly. So they sent these out. And I guess one of the challenges with sending out stuff by email is that you send a lot of emails out and you're not quite clear what your response rate was. And again, this I learned from this, that they have this technique where they send an email out and they give you the response rate based on how many emails they send, which is this 11% and 15%, which seems low. But then they can actually make it even quantify it down to how many people open the email, and then out of those ones, what's the response rate? So so that was it. I thought that was interesting. This is all the emails sent, and I guess people send emails and it's hard to know how many people look at them, how many people want to do them. And this is an example of a vignette. So 70-year-old patient with bladder cancer, metastasis to bone and lung, admitted under general internal medical team, hyperactive delirium, creatinine of 152, pre-admission ECOG of 3, has bled, which will look at what a has bled is, which is a risk of bleeding. Has bled of 2 means you've got a risk of 2 per 100 patient years. Basic information, how likely it would be to start this patient on thromboprophylaxis. Very likely, neutral, unlikely, very unlikely. So interesting. I could see this came into the acute hospital, it would be very likely. If it came to the palliative care unit, very unlikely. Be interesting to see what people think at the end, what their approach would be. And the variation the variation. So this is a has bled, just to give you an example of what makes you more prone to bleeding. This is based on atrial fibrillation, but apparently there's not exactly any great bleeding risk scores specifically for DVT, for anticoagulation for DVTs. It's much more for atrial fibrillation. So basically, if you have hypertension, abnormal renal liver function, elderly, you get all these scores. Now, again, just like the risk score for a clot, your risk score when you're in the palliative care unit is usually pretty high, because a lot of people have some abnormal renal liver function, which is 1, elderly, and may or may not have the other thing. So at least, I would be surprised if patients ICU in general would have less than 2, for example. So, but as you can see, when you start to get to 3 and 4, that gets quite high. But a bit like the prescribing for atrial fibrillation, people can find that hard to stop, even though their risk is low in the next year. So, so this is just showing you the variation. So the blue is medical oncology saying we would treat greater than 50% of these cases. And the next one is treat greater than 75% of the cases. So as you can see, medical oncology was, basically double each time how many people they would treat compared to palliative care, which is interesting. And these are the things I talked about. That actually there was 8, they're all designed. So 7's designed not to give it. I can't remember what it was, but 7 is designed that the correct answer is not to give anticoagulation. Obviously, they've got huge risk factors, poor performance status, a whole lot of things. But as you get pretty much, if you go through this on every scenario, oncology is much more likely, except for whatever reason, 2C, 2D, much more likely to give thromboprophylaxis than palliative care, and by a significant margin at times. So again, I guess that's really important to think just how our colleagues in medical oncology would think. Just in general, the odds were higher for people recommending thromboprophylaxis for admission to acute care setting, which we potentially talked about. Potentially reversible reason for admission. So if they thought they were getting, they were only temporarily decreasing in their mobility, and then they were having to move again, better performance status and low risk of bleeding. So basically, medical oncologists is more likely to recommend thromboprophylaxis compared with palliative care physicians. And I just wonder if that's more likely the fact that, in general, all medical oncologists work in acute care settings, and palliative care physicians can, as a general rule, work across different settings, subacute settings, palliative care units, community, those sort of things. So really, I think this is my last slide. So this is it's really interesting about what should we do in palliative care. And I think, so so we don't actually have any guidelines in my palliative care unit. We don't have any guidelines in our acute care setting, but everyone seems to get DVT prophylaxis, essentially because junior doctors just get it drummed into them to give it to every patient who comes in through the emergency department. So everyone gets that written up. And this question, should we have a blanket approach? Where not that we have a blanket approach in the palliative care unit, but no one gets it. And sometimes this question comes up, should we have given thromboprophylaxis? Should this person, some people get pulmonary embolism, some people get, lower limb DVTs, and then we think about what should we be doing. And I guess that I'm not sure in the Australian setting, anyone in a palliative care unit has a blanket approach to giving everyone DVT prophylaxis, because I personally think it would be very hard to justify on an evidence-based approach that you would be doing that, because there is no evidence, one, that it stops mortality. There's little evidence that it improves morbidity in the general medical population. let alone the palliative care population. Everyone is at high risk. But there is, I do think there may be an argument where we could better individualize DVT prophylaxis. So, you know, this setting where people are mobile and have an acute illness and they're temporarily decreased mobility and they're likely to get better again, are they the people who may benefit the most? You would think so, but that's not exactly what the evidence shows. And the other question is, when do we stop if started? So at what stage do we stop? And that sort of goes hand in hand with this. It's not just DVT prophylaxis, but it's really anticoagulation as well. Like, at what stage do you stop it? You know, do you stop when the patient's unconscious? Do you stop beforehand? Do you discuss with the patient? And what really strikes me is often I have a chat with junior medical staff, and I have this analogy with a spinal unit story. So patients in the palliative care unit come in, and often they become bedbound and they never stop being bedbound, and they end up dying, and they're bedbound as part of that. And so there's this argument, oh, they're very high risk, you should give them DVT prophylaxis. Well, in the spinal unit, people who come into the spinal unit and they all get DVT prophylaxis because they have back injuries, and they have you know, traumatic back injuries, they're bedbound or chairbound. They all get DVT prophylaxis. They continue it. And then I asked the junior doctor, so what happens when they go home? And they say they stop it. And they physically haven't changed one bit from what they're doing in that out. And the only reason in reality that I would be giving it after, I guess in the acute setting, you could argue the acute setting, maybe they've had surgery, all that sort of stuff. But after that, the only reason would be to not, so they don't get a DVT in hospital, which somehow has a bad thing for people, but they'll go home and I don't know if there are any more risk. So yeah, I'll be very interested in people's approach, to be honest, elsewhere. And any questions?
Fantastic. Thank you very much, Philip. Any questions or comments? I think you've romped through the inconsistencies and the unknowns beautifully. Thank you, Philip. Was somebody about to ask something?
Good evening.
Hello.
I'm Dr. Nazir from Sikkim. I would have one query.
Please.
Yeah, should I speak?
Yes, please. Go ahead, Dr. Nazir. Thanks.
It was an excellent talk by Dr. Philip. I want to know this one thing. In palliative care, in our settings, I don't know in your settings, patients are usually coming when they are very sick and in poor performance status. And you mentioned in one of the slides, patients with poor performance status have little benefit of thromboprophylaxis. So this is number one. And secondly, in our I'm a radiation oncologist basically. So in our wards, we do have routinely patients with loco regionally or advanced and even stage 4 disease. But their ambulatory and their performance status is excellent so far treatment is concerned. So should we give in those cases thromboprophylaxis because they are already prone to develop cytopenia because of chemotherapy and other drugs? So this query I wanted to clear.
Yeah, I think they're excellent questions. I think it's actually, I mean, one of the challenges is this idea of a systems issue. Like, it's much easier to give everyone thromboprophylaxis and give no one thromboprophylaxis. But as soon as you individualize it, it's much harder as an approach, unless you're very systematic. I think what it was saying in that slide, what they found in the palliative care units in the UK when they followed people was that getting a DVT when you have a poor performance status is much more likely a part of the dying process than a cause of it. And they didn't recommend that as a routine to give DVT prophylaxis. And I think you're right about, it's a little bit about that model, isn't it? About once you start giving DVT prophylaxis, the other question is, what should you monitor? Because it's not only in the chemotherapy and radiotherapy setting that people get pancytopenia, it can be advanced cancer as well. And so, yeah, the question comes up is how much you should monitor with it. Yeah, what do you do in your ward? Do you give everyone DVT prophylaxis or no one?
Okay, thank you.
So do you have a general practice for that, Dr. Nazim, in the ward? Does everybody in India tend to get DVT prophylaxis in an oncology ward? Would there be a general policy? Mm-hmm.
No, this is not a general policy, because almost only those patients who are bedridden or who are likely to have some disability and they are on beds only. And so only those cases we do. Routinely, we don't perform in those cases who are ambulatory, whose perform status is good, who tolerate treatment well. It's not a routine process, though, but we do it wherever it is needed.
Yeah, so it's a bit targeted. And I think, Dr. Kale, you've said similar, that if patient is mobilizing, then you won't give prophylaxis. Yeah. I mean, you mentioned Simon Noble, Philip, and I remember him speaking at, maybe it was an Australian conference or one, very strongly about the morbidity associated with DVTs. So your impression is that he's shifted now away from that position, is it? Or did they talk about? Yeah.
Well, my memory is that he was one of the ones who pushed a lot about having a lot of this idea of DVT thromboprophylaxis. And I was fascinated to see that he was the author on that study, which basically showed there wasn't much morbidity, and they concluded that you shouldn't give it from that point of view. And look, it's hard in the palliative care setting. There's one randomized controlled trial of DVT prophylaxis versus not. They were supposed to try, I think they were supposed to try and recruit something like 200 patients. They got 20 patients. And so it was very underpowered. They couldn't recruit to it from that point of view. So that was a real challenge in the setting. So, we don't really have great answers for that. I think, it's interesting to me in the palliative care setting I'm in, you are supposed to give DVT prophylaxis, even in the palliative care unit, except you're supposed to write reasons for not giving it. And things like, just saying things like advanced cancer is okay, actually, or, poor performance status is okay, or high risk is okay. From that point of view, I guess I've never really felt that comfortable with the fact that you're giving a treatment for something which is not a symptom as such. And we don't do that very often in palliative care. I don't know if we do that very much at all for, prophylaxis to stop a potential problem in the future, because it looks like it may or may not work. And it looks like not, 30% of people get DVTs when they turn up, but 70% don't have it.
Yeah. Are there any other questions or comments for Philip? And Neil? Yep, there you are.
Thank you, Philip. I would like to confirm your experience. When I've discussed it with patients, they almost universally say they want to stop the injections. You raise an interesting issue, though, about giving a treatment for the prevention of a future problem. And it's something that I don't have a clear answer on. Lately, in the literature, there's been maybe a little bit of controversy, or maybe just a debate about whether to give anticholinergics or medications for respiratory tract secretions in patients who are in the terminal phase, but giving that treatment, whether it's hyoscine or glycopyrrolate, before the problem has developed. And the concern being that, well, this is a medication, or these are medications that can actually cause side effects, but the problem being is that when the problem actually develops, then treatment is often then too late to have any meaningful difference. So in that situation, I do feel that there is justification. This is my interpretation of the pros and cons, that it is a reasonable to give it. I think that, and so both that as well as my own cognitive bias when I've looked after patients who have had sudden deaths, but I genuinely do feel that a clot, a PE, has been the cause of their death. I have been troubled by it because I wonder whether or not if the patient had have been given the choice, and the majority of the time I don't give them the choice when it's my practice in a palliative care unit, would they have actually said, yes, I would like that treatment? So it's a difficult situation, and I don't feel that I've got I have an answer or a clear plan as to how to manage that problem.
I think they're all good points, Anil, and that's probably a similar thing. The respiratory secretions is very interesting, I think. You know, I guess it's, and I think that's a great study they did, and it did show benefit. I think the challenge is I'm not sure any of us routinely give anti-secretory agents prophylactically, and maybe we're sort of trying to, I mean, personally, the way I would approach that is that if, as soon as they start to get a little bit of respiratory secretions, give a big dose. So go a bit halfway, I guess, in that setting, rather than give everyone it. And yeah, I think we need to get better predictors, don't we, of who may or may not get respiratory secretions. And you know, if you could, I think something like, I can't remember if it was about 30% of people end up with respiratory secretion. So 65 or 70% didn't. So that's a large number without, 30% with. If it was the other way around, if it was 60 or 80% of people getting respiratory secretions and only 20% without, I guess, again, my own bias would be that I think that would be worthwhile at some stage trying that. And I feel like you, exactly what you said, this is the issue, isn't it? When you get a patient who you have a sudden death and you think that could have been a PE, like that one I described, you think, oh, should I have given them DVT prophylaxis, and does it color your next one when you come in? So yeah, I think that's the challenge. I think it's a challenge of individualizing it.
Great. Well, thank you again, Philip, for covering that literature for us. And I think that challenge of individualizing therapies is remains with us. So I think we better move on, if that's all right, to our case presenter, which is Dr. Taylin Gurgenchi. Is that the correct way of pronouncing your surname?
Yes, spot on, or Dr. Tai, or just Tai is fine.
Okay, Tai, Dr. Tai, thank you. And I understand you're working with Philip at the Mater, I think.
Yes, that's right. I'm
at Queensland.
It's
so
spot on.
Thank you very much for agreeing to present, and thanks for the patience with all the registration links and the Zoom links.
No, not at all. I'm just really appreciative to be invited, so thanks very much.
Okay, well, over to you. Thank you.
Okay, I'll just try sharing my screen. I'll just make sure it's working, and I'll get started.
Okay.
So can everyone see that?
Thank you.
Okay, great. So look, thanks again. My name's Ty. I'm going to be talking about lymphedema in palliative care, but particularly around facial lymphedema. I'm not going to cover every slide in this presentation. I've just given an abridged version of the presentation itself, but basically I'll start off with a case. I'll talk a little bit more abstractly or just about the evidence around the pathogenesis of facial lymphedema. If we have time at the end, I'll talk a bit about peripheral lymphedema as well, but it may be that we run out of time for that, which is okay. These are my acknowledgements. Philip and Janet are my bosses and also my PhD supervisors who give me a lot of time to work on these sort of things, and also just acknowledging the various funders of some of my research time as well. So look, I start with a case which is published in Palliative Medicine, and there's certainly permission to use all the images that are used in this. I'll dwell on this a little bit just so we got context. A 63-year-old man with recurrent laryngeal squamous cell carcinoma was admitted to hospital in March 2021 for functional decline. But really the main issue was that he just couldn't see because his eyes were so swollen. Otherwise, he was managing to feed himself through his PEG tube or his gastrostomy tube. He was able to breathe through a laryngostomy tube, which he was no longer able to clean, again, because he couldn't see. There's a bit of a summary to the right about his previous treatment. It's all written by the patient himself, and you probably gather from the way that it's structured and written, he's quite health literate. In fact, he was a very intelligent man. He was an internationally renowned journalist. And this sort of intelligence becomes relevant later on in the case. I'm not dwelling on it for no reason, but he'd interviewed people like Kerry Packer, the Dalai Lama, multiple Australian prime ministers and British prime ministers. He had been married, but unfortunately his wife suffered and died from a cerebral aneurysm about 2 years into their marriage. And he told me he switched the life support off on April Fool's Day in the 1980s, and his in-laws still visited when I saw him 40 years later, and he had a photo of his dead wife by his bedside when he died, which I thought was quite sweet and quite melancholy. Like I said, he came in because he couldn't see, but otherwise he was able to walk 4 kilometers a day. He was doing quite well. 1 month into the admission, however, the swelling was so bad that it was no longer responding to the combination of daily prolonged lymphatic massage from our physiotherapist, exercises that he was sort of doing with the eyes, and frequent cold compress application. So these things were working, and then 1 month later they stopped working. He developed significant existential distress and was found to be much more easily frustrated by interruptions into his daily routine. He eloquently described, by writing, he was unable to speak, but he eloquently described how their efforts, the nurses' efforts at helping him in his newfound position of dependence actually worsened the distress that he felt because he was no longer independent. And he started asking about voluntary assisted dying, or some of you may know it as euthanasia, which he knew very well was illegal in the health service or in the state that we were living in. The tone of his written communication became much more pressured and much less contemplative. So look, to summarize, and I didn't sort of go into this too much, but there were no medications or radiotherapy or surgical options at this point, nor did he want to explore them. And this is a man who was quickly becoming functionally blind, even though his eyes worked fine. And he was becoming extremely distressed at the thought of this happening, and particularly of him lingering for weeks or months where he couldn't see and was completely dependent on others. Now, look, I was asked to stop briefly for questions at times. This is one place where I could stop and just ask how perhaps people might want to, or how they might manage this sort of this particular patient. I know though over Zoom it's sometimes tough to get takers, so I'll leave it for about 10 seconds, and if no one offers anything, then I'll move on to the next slide.
Ty, having had a similar experience with a patient like this, was there a facial mask available, or had that been trialled?
Yeah, it's a really good question. So yes, we had, in the outpatient setting previously, we trialled a facial mask. He was not interested in trying again. He found it quite intolerable. But it's an excellent question. It's something I talk about later as well. And it is something that's, in the literature has been helpful, but just not for him.
And given how common this head and neck cancers are in India, is this a commonly seen phenomenon in India, Dr. Iqbal or colleagues? Do you like to comment?
Yes, madam. We have one of the highest number of cancer in India in the Northeast, and most of the cancers are also head and neck cancer. This scenario is very common in our place. I can say that probably in Western countries they may see very few cases like this, but most of the 80% of our patient they present with this type of phase, with lot of symptoms associated with this. And it is, as Sir was saying, it is very difficult to control the lymphedema, and I don't know how much the suffering is associated with this patient. The swelling face, the ugly appearance, really, it's very common, madam, in our place.
Thank you. Well, we'll be interested in your comments as we go along, Iqbal. Thank you.
Thank you, madam.
Oh, that's great. So thanks everyone for that. I'll talk briefly about some pathogenesis, but I don't want to dwell on it because I don't think it's really the point of the presentation. What I would say is that on the right hand picture, I guess you can see different stylized histologies in the first row, and then with various stains in the second and third. And these link up to different types of lymphatics, which you can see in surgical specimens, and also the likelihood of seeing lymphedema and the stage the lymphedema will be in. for those who are interested in the pathogenesis, it really is quite an interesting paper to read, the references there, but I think I won't dwell on it too much. Similarly, look, this one's got some more pictures, so I guess in that sense it's a bit interesting. This is a lady who had radiotherapy for cervical cancer 6 months prior. And I know this is not the face, but the pathogenesis is essentially the same. And she started developing right lower limb lymphedema. And it'd be fair to say this lymphedema was on the sort of more severe end of the spectrum for the leg. And what they did when, I guess, they did this MR lymphangiography is you could see poor emptying of the vessel as well as significant leak, and that links back to the histology previously. So I don't know, it's interesting, I guess, you can do these investigations. I must admit, it's really a sort of a research setting sort of thing. I've never really ordered this sort of thing myself. I just sort of managed lymphedema as it is. So having said all that, let's try to apply some of this to facial lymphedema. Again, this is a study on by some colleagues in Brisbane and Adelaide and Perth, and they're sort of talking about how to describe lymphedema. They had a go at it using something called the Aloha method. I think a fair summary would be, without going into the details too much, that it's a method that's likely to be useful in the research setting because it's sort of reproducible in that sense, but it's really quite impractical in the clinical setting. And I think the bigger takeaway, or the bigger picture takeaway, is that we're still struggling to find a facial lymphedema grading tool which is both clinically and academically useful. I must admit, I struggle with it. And, you know, some people say someone's face is really swollen and you go to see it, you're surprised how not swollen it is. And sometimes you think something's really bad and you're speaking to a head and neck surgeon or something, and they think it's really quite mild. And doesn't seem to be a particularly useful way of describing them, though the tools do exist. So a general overview of, I guess, lymphedema management, and we'll talk a little bit about the novel way that we manage this gentleman's lymphedema as well. But and the ones in the rectangles I'll talk a bit more about, but there's compression, there's lymph manual therapy or lymphatic massage therapy. There are some surgical weight management, I won't go into it all, skincare, and there's also other therapies. So we use hypertonic packs for this gentleman. And I do have some before and after photos of that, and we published those in Palliative Medicine. And I must admit, for a very simple, you know, very cheap solution to the problem, which he could apply himself, it really did have a great result. In terms of the manual therapy, look, rather than just crowd the slide with dot points, I've just tried to put some references if you're interested. Dr. Voda, whose doctorate was in art history, described his sort of method of manual therapy in 1936. And there are many papers published on its application, and most of them are in German. And because Voda therapy is something which requires quite, as I've found out just reading about it, quite expensive certification to legally provide, there's actually something else that's cropped up called complex decongestive therapy, which is actually less complex than Voda therapy. And research has shown that it's non-inferior to Voda for upper limb lymphedema. But again, all of the evidence is just applied to the face. There's very little evidence for the face itself. In terms of compression therapy, so this is where you're literally just using a compression device to see if it helps, a pneumatic compression device. This is an interesting piece of research, mainly because I thought the pictures were quite telling. But the problem with this sort of thing is that the pictures are always good, but the improvement of where the dye goes is ultimately a surrogate marker for clinically meaningful improvement. And we really need better data than this to really see if it's been useful. And it's nice that the dye seems to be progressing through the lymphatic system, but does that mean anything for the patient in front of you? They didn't even comment on that really. And so it's just something to keep in mind, that there are fancy pneumatic tools as there are for other parts of the body as well. They have them for the face, but I think they're not really ready to be clinically applied, certainly in any sort of rigorous fashion. Although I would be interested if anyone is using them more often and what their experience was. So certainly my experience is not something that's commonly used in Australia, but maybe that's because we don't have the patient population. Anil did ask about facial masks. Look, all the studies that I found were pretty consistent with my small sample size, really, is that most people just stopped wearing them. Some of the other literature found that, they were helpful for those patients that wore them. But pretty much every study I found, the majority, and really the large majority of patients stopped using the facial masks. And I just include the photo from Amazon, which is actually one of the facial masks that was used in one of the studies and had very good reviews on Amazon, but I'm not sure. It is not really consistent with the study. Otherwise, look, I'll skip over this because I have a few pictures just coming up. You can get surgical treatments for the facial lymphedema. So on the left, we have some patients that have lymphaticovenular anastomoses 12 months post-op, and on the right, we have submental liposuction. And what I would say for this is, I think it's just striking the fact that these guys' facial lymphedema to start with is not too bad. So I sort of see these sort of options more as a cancer survivorship sort of intervention, where you have someone who's likely to do very well long-term, is unhappy with either the way that it looks or it feels, and you're trying to make it look or feel a little bit better. But certainly they're not approaching anywhere near the level of debilitation as the patient we're looking at before. So I guess, look, we've canvassed some of the options that are used in peripheral limbs, whilst considering the quality of the evidence supporting their use in the face, which is basically no evidence at all. And I guess I'd just ask you to think again about what you might do for this patient. You know, he's extremely distressed. He's pleading with you through writing that you offer to kill him because he's terrified to become dependent on other people whilst blind before the cancer has the decency to take his life. And you know, what would you do? There's a lot of suggestions coming from different people on the ward, I must say. You know, of course, different psychotropics were offered, anxiety medications, a psychology referral, pastoral care referral. We did offer all those things, and he was not interested in any of them. But our physiotherapist, Roz, had a thought. And one morning she said to me, you know, this is probably like 5 weeks in, 6 weeks in, and I've been thinking we use hypertonic pack therapy for lower limb lymphedema all the time. And I've never really thought about using it for the face, but I wonder whether it would work. And I thought it was a great idea and worth trying. And actually, probably my biggest takeaway, other than the fact that it worked, which I'll show you in a photo in a sec from this slide, is that, you know, I just thought, it took her 6 weeks to ask me that question. And I just wonder how many good ideas sort of go missing, maybe because people are shy about asking about things. So because she had been thinking about it some time after I asked her about that, but I thought it was a really good idea. I'm not going to talk too much about osmosis. Needless to say, the osmotic thing that you're putting inside the pack is what draws the water out. I think that's sufficient explanation. In terms of what we actually use, so in our paper we sort of describe it in detail, but I think these pictures really tell tell it in a nutshell. We use something called Baxter's soda crystals, really cheap. We put it in tubey grip. It doesn't have to be tubey grip, but that's just what we do because it seals up nicely. The patient can do this too. It's not hard. You just seal up both ends with some tape, and then that's it. You can wet it if you want, or you can apply it dry if you want. Doesn't matter either way. You can do it both ways. In terms of the face, so, you know, I had to, as we all do, de-identify the photos, but hopefully you can see in the first photo that he just, you know, he's trying to open his eyes in that first photo. He can't open them. And then we've applied the hypertonic pack. And in the second photo, you can quite clearly see that his eyes are open. That's after about 15 minutes. And once his eyes were open, he was easily able to keep making these packs. It wasn't a bother for him whatsoever. And he made a few in advance. Now, in typical fashion for this patient, look, he still grumbled about the fact that it was a bit of effort to have to do. And, you know, it stung a little bit and he didn't like that too much. But having said all that, all of the sort of harried and stressed out tone in his written conversation went totally back to normal. He wasn't stressed out anymore because he knew that there was an option to restore his sight, even if it did sort of annoy him a little bit to have to do it. And, you know, I think fortunately for him, a few weeks later, certainly well before this stopped working or well before this caused any side effects, he had an aspiration event and he passed away quite quickly and peacefully with some PRN medications. Rather than jump into anything about peripheral lymphedema, I might just stop there. If anyone had any comments, particularly just, you know, is that something that people have tried in India or elsewhere? I mean, this was novel for me, but, you know, it'd be really self-centered to think that it's novel for everyone. Maybe this is something that people are doing a lot and they apply it a different way. I'd be really curious.
Thanks, Ty. It's certainly novel for me. There are a couple of suggestions in the chat or questions.
Oh, yeah.
One's about, do topical steroids help? And the other is about, can you use sugar instead of the soda crystals? So
okay, yeah, really good questions. I'll just take them one at a time. So topical steroids. Look, I think topical steroids would, I mean, I won't say that it won't hurt. There's always that risk, I guess, with topical steroids near the eye of, you know, certain infections, like you are at risk of causing corneal ulcers and stuff on the one hand. On the other hand, look, I didn't try it. It may work. I think, I don't know if it would get quite the reduction of swelling that would be after. but it's definitely a thought, and I'm not sure. I'd be really interested to try one day and see. And the other question, can you use sugar instead of the soda crystals? Look, I'm not sure is the honest answer. What I think about is, I guess, you know, glucose as an osmotic agent sort of crosses a bit more easily. I'm not so sure how that would go, and maybe it would dissolve a bit quicker. I think these Baxter's soda crystals seem to work pretty well. You wonder about infection and sugar too, but again, the honest answer is I'm not sure. And you know, you could try it and see. I don't know. I don't know the answer.
So, any comments from the Indian participants, given your big experience with this kind of thing?
Hello, Dr. Tyler. This is Dr. Sandhya. I'm from the Department of Pain and Palliative Medicine from St. John's Hospital, Bangalore. So I've got a question for you, and thing that I wanted to just share. So the question would be, how would you differentiate just pure lymphedema of the face and, you know, superior vena cava obstruction that could be, you know, because of the lymph nodes enlargement? So what the picture that you showed, the face that we can see here, in India, probably we might have used steroid, we might have used dexamethasone just to reduce the peritumor edema and to see if in case it helps. So is there a way to differentiate the two is what I want to know.
Yeah, look, it's a really good question. Cut out briefly, so I'll just repeat it just in case it cut out for other people too. I mean, just essentially the question was, you know, how would you differentiate this from, say, superior vena cava obstruction? Is there a role for dexamethasone or a similar treatment in this sort of scenario? And look, I probably glossed over it, but this patient had dexamethasone before and had zero interest in dexamethasone again, not because he had a particularly adverse effect, but he thought that it was going to likely prolong his life. And also he was unusually fastidious with his diabetes management, and I think that sort of threw it off a bit. So in any case, it wasn't an option for him. Look, I must admit, and I don't know if Philip's still online or whether he sees it any differently, but we're quite spoiled at the hospital that we work. I mean, if I was worried about superior vena cava obstruction, I must admit I'm probably going to be leaning on the radiologists to give me a hand with that, and see what they think. But certainly your point's well taken. I mean, if that's the case, whether there's a role for radiotherapy and or, you know, high dose corticosteroids, or not in this patient but in other patients where there's even a surgical role, I think that's all very valid. It just happened to not be an option for this patient, and so we had to think a bit more creatively.
Okay, thank you. We've got probably half an hour left, and we do have another case, so I might limit the questions now and let you continue, Ty, if that's all right. There is another question in the chat, but we might be able to go back to that at the end if
no problem. I'm also happy to let the other speaker finish. I mean, either way, I'm happy.
No, that's fine. I don't know. Keep going.
Okay, no problem.
Thank you.
Oh, pleasure. Thanks for those questions. So look, what's happening here? There we go. So look, the rest is just a bit of a hodgepodge, a bit of a review of peripheral lymphedema, because I just found the first few times I gave this talk, I mean, unlike today, I suppose, I often got a lot of questions about peripheral lymphedema anyway, so I've just sort of tacked this onto the back of it. Interestingly, that the person who came up with the term palliative care was Dr. Balfour Mount, a urologist, and you do seem to get the odd person in palliative care who's still quite keen to stick needles into things. And so naturally the thought arises, if these legs are really swollen, and they do look really swollen, could you just, you know, pop them and reduce the swelling with a pin? And, you know, can we just stick a butterfly needle in and drain them? And I guess the answer in medicine is that you pretty much can stick a needle into anything, and people have certainly done it for lymphedema too, and they've had a fair amount of success. There's no really big studies, but there are quite a few case reports and case series. So you can do it for upper limb lymphedema, as Lau and colleagues showed here. They unfortunately don't have an after photo, but the table shows they've got around a 15% reduction in hand and forearm circumference. And you can see the volumes that they've drained there too. You know, they're not small volumes given that it's from the upper limb. You can also do it for lower limbs, as Lam and colleagues reported from Hong Kong. They found slightly less proportionate reductions in limb circumference, but otherwise, nevertheless, a positive result. These are, again, patients with advanced cancer. The natural question is, how much can you drain? And the answer sort of is, how big is your needle? Dr. Heng and Professor Hardy, who I now work with, but this is, a long time ago. Well, no, I shouldn't say a long time ago, but a while ago. Wrote a letter where they used a pretty big needle, and after application of topical anesthetic cream, which I think is important, they used 4 16-gauge needles, so large needles, subcutaneously inserted at an angle about 45 degrees in the medial aspect of both calves and the dorsum of the feet, and they were connected to a standard urinary catheter bag. And the patient was asked to sit out in a chair for gravitational assistance with drainage, and 3 hours post-insertion, a total of 6 liters had drained. And while the patient was in bed overnight, the bags were left on with the connecting tubes unclamped, and a total of 17 liters was drained over the next 3 days, with a resultant reduction in total weight from 88 kilos down to 71 kilos on the removal of the drains. And look, importantly, they go on to write that they have attempted this procedure on a number of other occasions with variable results. Some cases, no or minimal fluid drain despite repositioning. And they didn't recommend the use of this technique in any patient in whom all other options had not been trialed, and I guess that would include hypertonic therapy for the legs. But if successful, it can improve the quality of life in patients with end-stage disease. Characteristics they thought that might select for successful drainage. So people with spontaneous weeping of subcutaneous fluid and pitting but non-fibrotic lymphedema, but more experience is necessary to confirm this. It's often hard just to judge that level of fibrosis unless it's really obvious. They did add with some pride that no other cases report the large volumes removed in our case, and certainly that's true. I haven't found anyone that's had such a large weight. So I guess, oh, yep.
Sorry, Ty, I'm conscious of the time.
Of course.
Have you got just 1 or 2 more slides?
Oh, look, I'll just skip to the summary. I think that's fine.
Okay, thank you.
No, not a problem. So look, I think that the summary would really be, despite talking about a few things, there's very little high quality evidence regarding facial lymphedema management. Recommendations for limb lymphedema tend to be applied to facial lymphedema, and hypertonic pack therapy has been recently used for severe eye swelling, severe periorbital edema successfully. So thanks very much for your attention. What I could do, just looking very quickly at the text, I could perhaps send Odette a copy of the paper where we explain it in some detail, and then you could send it to Gori and whoever else was interested in how to prepare the packs.
Thank you. We'll do that. We'll usually send out a recording of the talk, and we'll include in a week or 2, and we can include that reference as well. Thank you very much. That was fascinating.
Not at all. Thanks for your time.
Discussion. And it's always good to be reminded that we perhaps can do more than we sometimes think we can in creative ways, and to remember that our allied health colleagues often have some expertise here too. So thank you. Iqbal and colleagues from India, I'm sorry, we probably need to push on to the next talk, but if you want to add any other thoughts in the chat about how you manage some of these patients, that would be fantastic. And I'm particularly interested in how some of the nurses, what sort of solutions they may be providing as well to try and care for these patients that you see with severe head and neck cancers. Thank you. So could we now just move on to a second case presenter, which is Dr. Geraldine Monteiro, who's joining us from St. John's Hospital in Bangalore, and works at the Department of Pain and Palliative Care there as a registrar, and is going to give us a patient story along the theme of the Philip's talk about pulmonary thromboembolism. So over to you, Dr. Geraldine.
Hello, madam. Thank you very much for this opportunity. I'm Dr. Geraldine, representing the Department of Pain and Palliative Medicine from St. John's Hospital, Bangalore. We are all here as a team listening to this lecture. So I will be presenting the case story of one of our patients admitted as an inpatient for terminal care. So I start with my presentation. The slides are not moving.
Just click on the screen and go to the next.
Try again, Dr. Geraldine. I'm sure it'll work. It came up nicely.
Yes. Old. She's a female patient. She got diagnosed this May with the diagnosis of cancer ovary with peritoneal and omental metastasis. She also presented with acute pulmonary thromboembolism, which was of a recent onset. She chose herself not to go ahead with any active oncological treatment and opted for best supportive care alone. Next slide. Presenting complaints. The patient, as I already mentioned, had got diagnosed with the cancer this year in the month of May. She kept visiting our OPD on need basis, mainly for management of her symptoms, which included pain abdomen, abdominal distension. On and off, she suffered because of poor appetite. And very often, we spent a lot of time addressing queries of this patient and the family, which were much to do with her prognostication of the disease. She did well over the months with just symptom management alone. On the 28th of November, she came to the OPD with acute respiratory distress, where she presented with sudden onset severe breathlessness, which was of grade 4. Since her general condition looked very sick, we routed her to the ER, where she got admitted under the acute pain and palliative medicine care unit. At presentation, her ADLs were severely impaired. She came in a bedridden state. There was also worsening of her abdominal distension, worsening of her bilateral feet swelling, and she also presented with excessive tiredness. Next slide, please. Yeah, coming to the history of illness. Following a detailed evaluation of a clinical condition in the emergency, patient got admitted in the acute palliative care unit. Her visits in the past to our OPD were mainly to do with her abdominal discomfort, where each time she presented with fullness in the abdomen, which required frequent ascitic tapping, which were done bedside. But since there was recurrent reaccumulation happening very frequently, and each time it would cause a significant amount of distress, we advised the patient and the family to go ahead with pigtail insertion. So after much of a thought process, they did consent for this procedure under ultrasound guidance, which was done on an OPD basis. Patient was comfortable after the procedure for about 10 to 12 days. She drained her ascitic fluid on a daily basis at home, which brought down her distress significantly. But when she came on the 28th of November, there was dislodgement of this pigtail and leakage of ascitic fluid when she presented to us for our admission. Next slide. On examination, patient was conscious, communicating, oriented to time, place, and person. She was extremely pale, had bilateral swelling of the feet. Her vitals, she was afebrile, pulse was around 130, she was tachycardic, BP in the range of 100/70. She was extremely tachypneic with her accessory muscles in action. Respiratory breath sounds were about 30 breaths per minute. She did not maintain a good saturation. She was at 80% on room air, but with 5 liters of O2, she was somewhere at around 93%. Her respiratory system on auscultation revealed reduced air entry on the left side, while her abdominal examination revealed findings of a distended abdomen, which was extremely tense with bowel sounds which were heard. Next slide. So we investigated her with the basic investigations. We did a workup for her renal parameters, where urea was found to be 40, creat of 0.7, LFT where total protein was 5.6 and albumin of 1.8. Her electrolytes, sodium, potassium, and chloride were 132, 4.6, and 104. Her PT-INR at presentation was around 12 with INR of 1. And just prior to discharge, it increased to about 14 and the INR went to 1.2. These were her GRBS levels. ECG was suggestive of a sinus tachycardia. Bedside ultrasound revealed minimum effusion on the left side. D-dimer, although is very specific for the diagnosis of an acute pulmonary thromboembolism, was not done. because the CTPA was very much in favor of an acute event, which suggested a complete thrombosis of the superior trunk and the interlobar pulmonary artery on the right side, with presentation of a left-sided pleural effusion. CT abdomen showed extensive disease with nodular and peritoneal omental involvement, with caking and local lymph nodal involvement. There was also moderate ascites. Next slide. So treatment, while in the emergency, the moment the diagnosis of thromboembolism was confirmed on the chest HRCT, she received injection Clexane, which was given at a dose of 0.6 ml subcutaneously, followed by which she was offered supportive treatment. Her BP kept waxing and waning, and so she was started off with IV fluids. In suspect of an ongoing respiratory infection, she was initiated on antibiotics. Then, because her BP failed to still pick up, she was started on noradrenaline support with running at around 8 mg at around 6 cc per hour. She also underwent an ascitic tapping because there was significant respiratory distress, where about 2 liters of hemorrhagic fluid was drained. The guarded prognosis was discussed in detail by the emergency doctors to the patient family, followed by a detailed discussion by the pain and palliative care team. Next slide. So psychosocial aspects, like any other palliative case, I thought I would bring it up in covering these 4 domains. Physical symptoms, what the patient presented at the ER was a fear of breathlessness, fear of experiencing pain, and fear of experiencing other new distress which would come up. Psychological, she had a lot of fear that she would die. The fear of death and dying kept disturbing her a lot. Social fears, social domains, she was supported by her daughter and also her husband and her son-in-law, who were her primary caregivers. They cared a lot for her and they were with her all the time during the course of the disease trajectory. So she had this immense fear of dependency on her caregivers, the fear, like any other palliative patient, of being a burden to them. Spiritual domain, she had a desire during her lifetime to make various visits to religious pilgrimages, which she has been planning over the days, but it has never materialized. She also had this immense desire of offering some gold offerings to her god of worship, and she has been holding this desire from the past 15 years and unable to fulfill it. So these were the moments which brought in all these thoughts to her mind, which added on to her overall distress. Next slide. So over the course of the days, patient showed remarkable improvement. Her general condition improved. She began communicating. She even attempted ambulation. So we planned discharge over the days. So we discussed her discharge with the family in terms of pharmacological management and non-pharmacological. Pharmacological management, a take-home card was prepared by the department to explain each and every medicine which is to be continued by the patient post-discharge. So we discharged her on tab paracetamol for managing her background pain. She was advised to take this analgesic round the clock. We switched her over from parenteral anticoagulant to tab dabigatran, which was an oral anticoagulant. She was advised a dose of 75 mg, which was a BD dose. The family was instructed to get a repeat PT-INR of the patient done after a week. We are yet to get back with the report. We haven't still gotten back from the patient regarding this report. Then we also advised lorazepam because we anticipated that the patient would land up having further episodes of acute breathlessness in the future, and Dalcolax for managing her constipation, which kept disturbing her now and then. Non-pharmacological management, we advised the graduated compression stockings, which are TED stockings. We also prepared the family that she would constantly need oxygen post-discharge. So we helped the family arrange for an oxygen concentrator, go for a nasal prongs, keep the non-breathable mask as a standby in case the patient landed up having acute hypoxic spells. Then we also advised hospital type prop-up bed for the patient so that, every time she went into distress, the proper position would give her some amount of relief. We also helped the family to liaise with continuity of care by providing them contacts to go ahead with home care. Next slide. So what were the main concerns that we experienced with this patient and the family while the patient was admitted with us? So this was a patient who, despite having the diagnosis of cancer, did fairly well over the months. And it was a sudden shock to the family. It was hard for them to believe the sudden deterioration in the patient's functionality. So it was very hard for the treating team to make decisions with the patient's family regarding prognostication. Any discussion about death would cause the caregivers to go into a belief of total uncertainty. They were not ready to accept the prognosis that it would go in either for recovery or death. So this made our decisions difficult because there was a lot of pending decisions regarding DNR consent, as in shift of the patient to the ICU in case of a sudden deterioration or a hemodynamic crash. So these decisions kept bothering them because they were totally not mentally prepared to accept death as one of the immediate outcomes. So also another main concern that we anticipated with regard to managing this case was, how do we go about managing this patient with anticoagulants in the palliative care setting, given her age and her background with an advanced malignancy? So these were the main concerns of the treating team while handling the patient and her distress. Next slide. So to sum up my case, Mrs. M, 68 years old, diagnosed with metastatic carcinoma of the ovary, presented to us with sudden onset of severe breathlessness. At diagnosis, found to have an acute onset pulmonary thromboembolism, shifted initially to the acute palliative care unit, was treated initially with parenteral anticoagulants, where she showed remarkable improvement. She began ambulating, she began communicating, hence a discharge was planned for this patient, where we switched the patient to oral anticoagulant and asked her to report to us a week post-discharge with a couple of blood tests. We also phone followed up this patient and we gathered from the family that the patient was doing fairly well post-discharge. So the points for discussion which we have compiled are, in a patient with already existing hemorrhagic ascites, how do we handle anticoagulants? How far should we go and where do we stop? Secondly, regarding the prognosis of this patient, the case being so very precarious, what policy do we take as healthcare professionals in initiating and continuing anticoagulants? So these were the main points we thought we should hold a discussion in managing these type of patients better in a palliative care setting. Thank you very much.
Thank you very much, Dr. Geraldine. I must admit, as you were going through the story, I wasn't expecting a very good outcome. So it was quite nice to hear that the patient did so well, actually. But could I throw those questions over to Philip as our faculty expert from this evening, and then invite other comments from other participants?
Thanks, Odette. I think that was a great presentation. And yeah, as Odette said, I think you did great. The patient got home, which is fantastic in all that. But I think it's, as you said, it's a real challenge about what do you do in the setting of bleeding and anticoagulation. And I guess personally, I have an approach of, I guess trying to work out how much bleeding is significant and how much bleeding is not significant. So I'm not sure whether this is the best approach, but I would use, are they dropping their hemoglobin or not would be my sort of outcome measure. Are they getting symptomatic or not from the bleeding? And I personally have a very low threshold for stopping anticoagulants once people start bleeding. I think it's a challenge, as you presented, when someone's just had the pulmonary embolism. Certainly once they're a week or two or more past the pulmonary embolism, I have personally a very low threshold that if bleeding is causing a problem, in which case you think they're going to run into problems with bleeding. And I'm really I think when you experience, I mean, Anil talked about, your patient having a sudden death and you wonder, should I give them anticoagulants? when you have the experience of having patients with anticoagulants, and especially with these direct DOACs or direct oral antithrombotic agents, you know, they're at risk of, if people will develop renal impairment. And I can remember one place I worked, the first patient we put on these drugs developed renal impairment unknown to us and had catastrophic PR bleeding and almost died from that. And once you experience a patient has catastrophic bleeding, it makes you biased about stopping the anticoagulation. So I think you've done really well just managing the patient.
Thanks, Philip. Any other comments from Indian colleagues as to how you would go about managing this situation? Would you do a similar? And again, knowing the sort of patient and family expectations is also a very big factor in perhaps encouraging treatment in a certain direction. I don't know if that was a big factor for you too, Dr. Geraldine, in your department, the expectations of the family here.
Yeah, it was very hard to manage the family's concerns. They had a lot of doubts whether the patient would make it or not. So each time we had to hold a counseling, make them understand, at the same time prepare them that death is not too far away and anything can happen. So it was a very difficult discussion to hold with the family each time.
And did they tend to want more towards treating or not treating in terms of the anticoagulation? Did that feature a lot?
Yeah, they were in favor of treating. We just thought we would give it a try. If she improves, she would improve. If she worsens, we thought we would put a full stop. But then for our good luck, she did show remarkable improvement. And then, you know, we decided to go ahead with it. So the family also was quite satisfied that it yielded good results.
Yeah, thank you. David, please.
Hi, can you hear me?
Yes, lovely, thank you.
I think there's great difficulty in deciding whether to anticoagulate a patient such as this, but I must say it's a very reasonable thing not to, as well as doing these things. It's very easy, isn't it, to do them because it seems appropriate. I guess, as Philip said, it depends a bit too on the bleeding, whether the bleeding that was evident on the tap was due to the tap itself, or whether it was due to blood to actual hemorrhage in the acidic fluid is an interesting question, and deciding on that might help you to decide which way to go. But there's another aspect to this patient's treatment that I wonder about. I think you did a great job of caring for her, and certainly in no great way did it differ from anything I would have done, except in one way, and that is that it's pretty traditional for us to use opioids to relieve breathlessness. And I wondered if there was some issue in the availability of using something like oral morphine, which, as we all know, is a very effective way of relieving the breathlessness. And particularly when she was going home, and if the breathlessness was an ongoing problem, would it have been reasonable, or did you consider that, or do you think it might have been useful to use an opiate of one kind or another to help?
We have never given a try using morphine for this patient, although we do agree that morphine would definitely help in this case of handling breathlessness. We did not give it a try.
Thank you.
I think perhaps it's not something you do routinely, but it's certainly a great medicine for the treatment of breathlessness as well as the treatment of pain, and just in very small doses. And we could talk about that at some other time, but it's certainly useful, and be worthwhile if you see a similar patient in the future, considering it just for symptomatic relief. But congratulations on both the patient's management and on your presentation. It was great.
And just a comment also, we will have to wind up, but I see Gary has popped something into the chat, Geraldine, about using would enoxaparin have been a possibility, but noting the expense and the fact that it needs to be injectable, but would that have been considered for this patient as an outpatient?
Enoxaparin, we gave it as Clexane, and in the inpatient setting, we had given it in the inpatient setting. But since it requires administration by a medical personnel and frequent monitoring and administration is difficult post-discharge, we decided to switch her over to oral anticoagulants.
Sure. Yeah. Okay. Thank you.
A very quick comment.
Yes, sorry, Anil.
Sorry,
please.
It was just to say that in my understanding is that monitoring of the INR or the prothrombin time is not helpful with these anticoagulants, because they will just all be abnormal, but just the dosing is the standard, and you just proceed from there.
This is for people on the DOAC.
Correct.
Yeah. Well, sadly, we've come to the end of the session and the end of our program for 2022, and I think we've finished on a great note. So I really thank the presenters again, Philip and Kay and Dr. Geraldine and Dr. Kale. Thank you so much for your faithful attendance at these sessions, and thank you also to others who have also been here each session, Penny and Anil and everybody. And I guess we are hoping to resume in 2023, but we probably will ask you for your feedback about that, and always happy to hear of topics of interest, always very happy to have volunteers to present cases and topics. And we have had a focus on the faculty presenting from mainly have been from Australia in the last 6 months, but it should no means be limited to Australian presenters as faculty. And so we might try and reach out a little bit more to some of our Indian colleagues to do the initial talk if we do continue again in 2023. I'd love to ask you whether there's interest in doing that, but I don't want to put you all on the spot now. But perhaps you could communicate with the TIPS team any ideas that you have, whether or not we should continue the program. But I just want to say thank you all very much, and